The Genuine Article. Discussion and commentary based on articles from Jack.
Hello, I'm Tony DeMaria, the editor of Jack, here with Inside Jack, and I'm talking to Dr. Aslan Toura. And Dr. Toura is assistant professor of medicine at the University of Texas Southwestern, and he's authored an interesting article about to appear in Jack that deals with the specificity, really, of these very new high-sensitivity troponin assays. And in this study, they conducted what I think is really a clever protocol, and they aimed to answer the question as to whether or not one could detect levels of troponin by these high-sensitivity assays, even in the absence of infarction or presumably cell death. And the model they used was rapid atrial pacing to ischemia that they verified by coronary sinus lactate production. And interestingly, found that, in fact, just with pacing, one could detect increased levels of troponin by the high sensitivity assay in the absence of myonecrosis, and in fact even in patients without coronary disease. So Dr. Toura, tell me, in the past we've accepted troponin as evidence of cell death. Does your study really refute that?
Well, I think it represents a set of novel findings that probably tie together some of the other information we had from, for example, marathon runners, where participants, otherwise healthy people who would participate in vigorous activity would be found to have elevated troponin levels, and it was always very puzzling. And the presumption to this point had always been they had small amounts of myonecrosis. So I think, in answer to your question, yes, I think this is a little bit of a potentially a paradigm shift, that maybe these very small levels of troponin are not necessarily indicators of myocardial infarction per se, but maybe just indicators of myocardial ischemia instead. And instead of a threshold effect of infarction, we should be thinking of troponin release potentially on a scale from ischemia to infarction, and rather than a threshold effect.
Well, but I have a question about that, because even in patients without coronary disease and in whom lactate production was not verified as indicative of ischemia, you still detected elevated levels of troponin. So is even ischemia required?
Well, that's a good question. It may be that this is sort of a very small level of ischemia that we were unable to detect by small shifts in lactate, or maybe this is just an indicator of even the normal amount of cardiac work that a person undergoes during the course of a normal day or running for a bus, that we would see small levels of troponin elevation that may be in fact normal.
So I guess as a bottom line, based upon your findings, how are you using these high-sensitivity troponin assays now? Or are you requiring a greater degree of elevation before you're suspicious of disease?
Well, in truth, we haven't been utilizing these assays clinically here, but I think it does caution us that we have to be very careful in interpreting the meaning of very small levels of troponin in the serum in patients who come in with chest pain. I don't think it's possible to just depend on a low-level troponin or even a serial change in troponin measurements, particularly if those troponins are underneath below our threshold for these assays in terms of the upper limit of normal. To automatically assume that somebody has a cardiac reason for their chest discomfort. I think further research is going to have to be done in terms of looking at relative and absolute changes in troponin over serial measurements before these can be safely adopted to all patients in all situations.
Well, there's no question that we've had a number of patients admitted to our institution with elevated levels of troponin by high sensitivity assays who've proved to be absolutely normal. So the enhanced technical ability of these assays actually may be causing a bit of a clinical dilemma. Your data will help us sort this out. Thanks very much for being with us. For Inside Jack, I'm Tony DeMaria.